Hi, this is Jane Taylor. I'm an improvement advisor with the Society of Critical Care Medicine, and I've been working on the Surviving Sepsis campaign. And today I want to talk about scale up and spread. So before we get to spread, we need to implement a change on a pilot unit. And that pilot unit takes this better idea, this change, and makes it permanent on the pilot site or the pilot unit. And that is called implementation. Now, during implementation, we're going to encounter some systemic barriers and perhaps infrastructure issues that need to be addressed. And these barriers or issues will inhibit the spread of a better idea. So it's really useful if they emerge on the pilot unit so that we can overcome whatever that systemic barrier is or that infrastructure issue that would inhibit spread later on. So spread is just simply the replication of the changes, the better ideas that we've tried and perfected on the pilot unit with other people and with other sites. So I wanted to provide an example from our sepsis work to reduce sepsis mortality on medical surgical units, and that is about screening and response. So we are implementing screening every patient, every shift. Well, this requires a lot of work to implement it. It means we have to redesign flow, how the work gets done. We have to develop methods of simulation of response because the sepsis incidence may be low enough that we're not practicing the response. So just like we have simulated fire drills, we might have simulated responses to sepsis screen. There needs to be role clarity about who does what, and also job description changes. Training has to be instituted so everyone knows how to incorporate these changes into their job, and then some thought about what needs to be added to new hire orientation, because after all, the job may have changed because of these new requirements. And there's policy and procedure that follows that begins to codify the new way of doing things. And then we need to make sure that we've created a standardized work and way of doing the work with specifications about what needs to be done and how it's done. And then what are the documentation requirements of the new way of doing things, of screening every patient, every shift. And then what kind of protocols and nurse-driven protocols do we want to have around the response process.
So Jane, hi, this is Lori Harmon at SCCM. May I ask a question, please?
Oh, great. Go ahead, Lori.
Do we need to have every barrier resolved, every change perfected before we move to spread?
Well, here's what I'm thinking about. If we're talking about screening every patient, every shift, the pilot unit needs to figure out how to do that and how to do it right and how to do it reliably and have really worked on this, what I might call an implementation checklist. And there's a great implementation checklist in the improvement guide that's published by Langley et al. By Jossie Bass, if you want to learn more about implementation. But we might actually parse apart screening and the response and think of them as two changes instead of one. And if we think of them as two changes, as soon as you get the screening process reliable and you've worked on all of these implementation aspects, it's ready to be exported or spread. And you might do that while you're still working on the response and the nurse-driven protocols. So every little bit doesn't have to be completely perfected before you change. As soon as you get a better idea ready, it can be handed off to the next unit. Does that answer your question, Lori?
Yes, it does, and it makes sense as we think about the other units might have input to help us further perfect the process. So thank you for that, Jane.
Exactly, and we need to remember to keep those communication lines open so that we can revise and even better our changes as we spread them across the institution. So the scale up, one of the useful things that Associates Improvement and the Institute for Healthcare Improvement has taught me is that scale up could be best done in increments of 5. So if I have this change of screening every patient, every shift, and I get ready to spread it. I might want to spread it from 1 unit to 5 units. And the reason for that is that we want these systemic barriers to emerge. And sometimes if you're just working on 1 unit, the unit can develop very elegant workarounds and ways to get the job done, dodging some of the systemic issues. But when you move to 5 units, you can't do that. And so these systemic issues will emerge. And it's valuable because that's what has to be overcome in order for the rest of the spread to be successful. And so it's recommended that we scale up in increments of 5. So we would go from the pilot unit to 5 units to 25 units to all, for example, from 1 hospital to 5 hospitals to 25, and so forth. And that is very purposely done in order to be a forcing function to get the infrastructure issues and the systemic barriers exposed. So an example might be that there's no place to document these shift screenings for sepsis. And that's going to affect whether and how we can collect data to understand are we doing it reliably or not. So that's an example of a barrier where senior leaders have to step in and say, we'll get IT to move this up higher on their list of priorities because it is part of our spread plan. Many systemic barriers and infrastructure issues do require senior leader cooperation and engagement and intervention to overcome. So that's why on some of our other discussions and some of the other recordings I've talked about the importance of leadership in scale up and spread. So just a reminder, spread is when we are moving from our pilot unit to all medical surgical units or moving to hospitals within a healthcare system. Thank you very much. Good luck with your spread.